Polycystic kidney disease is a group of genetic diseases that are characterized by the formation and growth of renal cysts. The disease is characterized by bilateral development and enlargement of fluid-filled renal cysts. Although cystogenesis starts early in life, symptoms typically will not manifest until adult life. ADPKD occurs in approximately 1 in every 500 to 1,000 live births in Canada. This is equivalent to about 35,000 to 70,000 individuals living in Canada with ADPKD. Two disease genes cause ADPKD when mutated: PKD1 on chromosome 16 and PKD2 on chromosome 4. A mutation in either of these genes leads to the production of abnormal polycystine proteins in the renal epithelial cells. These abnormal polycystine proteins cause lower intracellular levels of calcium, leading to higher intracellular levels of the second messenger cyclic AMP. In ADPKD, an abnormal response to the increased cyclic AMP occurs. This response includes proliferation of the renal epithelial cells and fluid secretion into formed renal cysts. This abnormal response of cell proliferation and fluid secretion also occurs when cyclic AMP is increased by vasopressin binding to the vasopressin V2 receptors in renal collecting duct cells. This is important in the pathogenesis of ADPKD because patients with ADPKD have high levels of circulating vasopressin due to an early defect in urine concentration capability, and they have an increased expression of the vasopressin V2 receptor. This cell proliferation and fluid secretion in response to increased cyclic AMP leads to the cyst formation and growth seen in ADPKD. Cyst development and enlargement in response to increased cyclic AMP is progressive. As the cysts continue to increase in number and size, the kidney volume increases and renal tissue is progressively damaged. As the damage progresses, more functional tissue is lost. A decline in renal function is not seen initially because of compensatory hyperfiltration in the undamaged nephrons. However, this progressive loss in functional tissue leads to a decline in renal function once glomerular hyperfiltration is no longer sufficient to compensate for the lost nephrons. End-stage renal disease eventually develops, resulting in the need for renal replacement therapy. Approximately 50% of all patients with ADPKD will have end-stage renal disease by the age of 60. ADPKD also is characterized by extrarenal manifestations that often include cysts in other organs, abdominal hernias, mitral valve prolapse, and aortic root and intracranial aneurysms. Cysts develop in the liver, pancreas, spleen, seminal vesicles, and arachnoid membrane. Patients with ADPKD often have signs and symptoms such as flank pain, renal colic, urinary tract infections, hematuria, and hypertension. Despite these signs and symptoms, ADPKD may not be detected for several decades because renal function often remains normal until the total kidney volume has approximately quadrupled in size. At this point, more than 50% of the renal parenchyma has been damaged, and hyperfiltration in surviving nephrons can no longer fully compensate for all of the damaged nephrons. This decline in renal function is indicated by increased serum creatinine levels. Once the kidneys have reached a size in which a decline in renal function has been detected, further decline in renal function can be rapid due to the increased rate of total kidney volume progression that occurs as the kidneys get larger. As illustrated in this graph, greater total kidney volumes are associated with greater rates of total kidney volume progression, which leads to greater rates of disease progression. Early diagnosis, therefore, may help slow disease progression and the decline in renal function. Patient knowledge of family history of ADPKD can result in earlier diagnosis. Patients should be made aware of the chances of inheriting ADPKD if there is a positive family history. Because it is an autosomal dominant disease, only one copy of either mutated PKD gene is needed to inherit the disease. Therefore, there is a 50% chance that a patient may have inherited ADPKD if one of their parents had the disease. It is important to note, though, that although inheritance is the main way of acquiring ADPKD, patients may also acquire ADPKD through a spontaneous mutation. The spontaneous mutation is thought to occur in about 5% of all ADPKD cases. In about 25% of all newly diagnosed cases of ADPKD, there is no clear family history, suggesting that ADPKD often goes undetected. Patient and physician awareness of the hereditary basis of the disease and family history, therefore, is critical in early diagnosis and management of ADPKD.